At my institution, we try to see patients at the 2-week postpartum mark and again at 6 weeks. Our visits are anywhere between 20 minutes to 40 minutes if we're lucky, and I'm often trying to juggle a checklist to ensure my patient is recovering appropriately, aware of any risk for future pregnancy, and ready to face the future with an additional identity of a new parent. And this is if everything else during this period is going smoothly. So let alone if there's a baby that's crying, there's another issue that's come up. Sexual health and intimacy often get relegated to the end for a 2 to 3 minute discussion. However, we could argue that sexual health and intimacy are one of the most important topics to cover, as tired, stressed individuals learn how to juggle the role of parent, partner, and self, along with all the other hats that they wore pre-pregnancy. Today, our discussion will center around 4 key parts: a review of sexual health problems, postpartum physiology and its role in sexual health, the role of pelvic physical therapy, tools and resources to support sexual health, and finally, we'll leave about 10 to 15 minutes for Q&A at the end. Before we get started, we'll see if the poll results can be published. Let me see if I can access them. Okay. So almost 50% of you are located on the West. Otherwise, no one from the Midwest today. We do have a third of you from the Northeast and about 20% of you from the South. In terms of who's in our audience, we have about 23% of you are superheroes expecting our new parents. We have a few MDs and DOs in the audience. About 15% of you are midwives of some sort. 23% of you are doulas, and about a third of you are other. And then in terms of your what you have used in the past or recommended to address sexual health postpartum, it sounds like it's, oh my gosh, almost 3/4 of you know about pelvic physical therapy, which is fantastic. Hopefully you'll learn a little bit more. About 20% of you have recommended toys, vibrators, and lubricants. A few of you have recommended apps. I'd love to know what the other is. About 40% of you put other, so hopefully we'll have a chance to discuss that too. Without further ado, I'd love to get started. With Dr. Lindsay Harper, let's start with you. You're a board-certified OBGYN, founder and CEO of Rosie, an app for women with decreased sexual desire and other sexual problems. It's so good to have you today. Thank you for joining us.
Well, thanks so much for having me. I'm thrilled to be here, and this is such a fun panel. It's been fun just even preparing for it. So I can only imagine how much fun we're going to actually have today. And I'm thrilled to know about everyone that's in the audience and just to talk more about this. I think that that's the most important thing that we can do. And I appreciate the opportunity and June Motherhood supporting this, is just really talking about women's sexual health kind of as frequently as we can. So I appreciate this, this chat today. So I'm going to start us off kind of by sharing some clinical pearls about just women's sexual health in general, and as practitioners, how we can try to open up that conversation and just give us some background that maybe some of us missed out on our training. You ready for me to get started there?
Yeah, and just so our audience knows, we'll be introducing the other panelists as we go along. We have Dr. Justine Williams-Roper joining us from Pensacola, Florida, correct? And Dr. Sherlina Bogart, who's also an OBGYN, who can be found in many locations, but today she's coming to us live from Puerto Rico. So envious of that location. But yes, Dr. Harper, if you can start us on a crash course on genital anatomy and common sexual health problems to make sure we're all on the same page. I know there's different levels of understanding in this group. So please, I'll let you get started with your presentation.
Absolutely, and it'll be short, but hopefully it'll be full of some good information. All right, so my whole goal in my life is to get us to have more of these conversations, and when we're in the room with our patients or our clients, whatever capacity we're seeing these women in, for us to get more of those conversations about sexual health started as well. So when we think about it right now, when a woman has a sexual health problem, who's she supposed to ask, right? Is she going to Google it and then be bombarded with some like pop-ups that maybe she wasn't planning on seeing, or maybe get some advertisements that she wasn't counting on, or maybe she'll visit like a brand that is maybe making a comment about women's sexual health, which I appreciate, but then also maybe selling some products that aren't necessarily evidence-based, and that may not actually have a helpful effect for a woman. So, what I like to talk about whenever I am speaking on this topic is that actually it's us that our patients should be asking about their sexual health, right? We should provide a safe space. We should have the training and knowledge that we need to help these patients with sexual health problems. But for a lot of reasons, most of us don't. And that could be usually because we don't have enough time and our practices isn't prioritized in terms of reimbursement. It's not prioritized in terms of checklists that are handed down to us by our governing bodies. We sometimes are nervous. Like if I ask my patient about, her sexual health or her orgasm, or if she's having, painful sex, what does that mean about me? Right. And what about if my patient gets offended? How could that change the relationship with my patient, maybe negatively? And so that feels a little bit risky sometimes to us as practitioners. And then lastly, I think a lot of us ourselves haven't, just kind of goes back to not enough time or not enough training, is that we aren't really quite sure of the language we're supposed to be using. We might be nervous about, starting and facilitating these conversations. And that all just gets better with practice and with modeling, right? So if you've had the training that you need and you are aware of, how to ask these questions, which is part of what we're going to do today, then that becomes a little bit easier. And I really feel very, strongly that we as women's health providers in all capacities should ask, because it can save our patients' relationships, it can improve their lives significantly, and it deepens that provider-patient trust, which is to say that, if they can come to you with whatever, and they know that it will be treated with respect and with acceptance, then that really goes a long way in the longevity of the relationship between the patient and the provider. So just quickly, there are a lot of us out there still calling a vulva a vagina. What? Gasp. I know that nobody on this call does it, but in case you hear it somewhere else, I want you to feel empowered to tell people that everything you can see on the outside, the external female genitalia, is called the vulva, right? Viva la vulva. That's our little hashtag. And we don't want that to get washed away. We don't want the external genitalia to be called the vagina. The vagina is what you can see with the speculum. That's where we put tampons. That's where we examine in the gynecologist's office with an internal examination. The vulva is what we see on the outside. And it's really, really important that we teach that to our trainees, that we teach that to our patients, that we teach that to our children and our partners, because the more that we can normalize that language, the more that other women and their partners feel empowered to discuss these things in a sort of nonchalant, evidence, fact-based manner. And, we definitely don't need to use other words like, slang words in the office with our patients, which I'm sure most of us don't do, but we definitely need to be calling the external genitalia the vulva. So the clitoris obviously is at the top, the urethra, the vagina, the labia, the anus. I'm sure you guys know this. The point of that is to call this the vulva. And another important takeaway from this is that the clitoris, actually, all we see in this picture is just the head of the clitoris, but it actually extends down into the labia minora, the labia majora, and then back into the vagina for many women. And the actual length of the clitoris oftentimes can be between 8 to 10 centimeters for many women. So it's actually a lot.
Dr. Harper, okay, that is not a well-known fact. Let's just let everyone hear that again.
It's not.
It's more than just the organ that is at the hood or at the top of the vulva. Say it extends into the labia minora, and it can be up to
absolutely
8 centimeters.
Yes, it is. It is. And so here's the thing. So all we're seeing at the head of the clitoris, the bulb that's external, is the very tip, right? But it actually extends down, like it's called the legs of the clitoris, and it goes down into the labia And for many women, actually extends back into the vagina. And so when we're talking about things like the G spot, things like that, it's what many of us think, including myself, is that it's actually an extension of the clitoris going back into the vagina. So when many women come and they say, I've never been able to have an orgasm, when you drill down into that, what they're saying is that they've never been able to have an orgasm through penetrative sex, through vaginal stimulation. And for some reason in our society, we've really normalized penis and vagina sex, right? And that's the way that women have orgasms. And then if we don't have orgasms in that way, that something's wrong with us or we're broken. But in fact, the numbers kind of vary with this study, but between 75 to 95% of women have orgasms through clitoral stimulation. So we need to be spreading that information. When a patient comes to us with an orgasm concern, that is the first thing that we need to cover, because if she has clitoral stimulated orgasms, she's completely normal. Nothing's wrong with her. Everything's fine. But we have to just do a better job of talking about that and portraying it in movies and books. Okay, so there's our first little clinical, or maybe second for the day. And the second thing that I wanted to just bring up is how common these sexual complaints are, right? Women that we see in practice often think that they're the only ones suffering with these sexual problems. So I think these numbers can be really empowering, that any dysfunction is seen in 44% of women, right? So almost half of the women we're seeing, whether they're postpartum or not, that number is going to be way higher in the postpartum group. This is all women ages 18 to 65. 44% of them in this study, the Preside study, had a sexual problem. 38% of them reported decreased desire. 26% reported trouble with arousal. A fifth of them reported trouble with orgasm. So that could be delayed or diminished or absent orgasm. And then we also often couple that with this distress factor, right? So if a person has low desire, but they don't really care that they have low desire, then we don't need to worry about treating that, right? We're not going to medicalize a problem that's not a problem for the patient. But when 10% of the population have low desire plus distress, those are who we really need to be checking in on and seeing how we can help. So I think this is just really informative to show us how widespread these problems are, and to help also normalize these issues for our patients so that they don't feel, as one of my patients said, like she had 3 heads. People feel so broken and so hopeless when they're having sexual difficulties, and we can really help with that by normalizing and then offering some evidence-based solutions.
I would say
another.
Oh, sorry. I was going to say, I don't.
No, go ahead.
I don't think anyone would think that 44% of the population who identifies as female would say that they have a sexual disorder. And because it's something in my practice, like when I've asked about it, oftentimes people say, you're the first person who's ever asked, or I didn't realize, like, it's not, that there are other people that could be affected by the same thing. So everyone who's in this list today or joining, please tell at least 1 or 2 other people how commonplace this is, so that we can start addressing it more commonly.
Absolutely. Love that. That would make this all a success. That would be amazing. Okay, so the next thing that I want to just go over briefly is this idea of spontaneous sexual desire and responsive sexual desire. So when Masters and Johnson were first studying sexual desire and sort of the whole sexual response system in the 70s, they just actually didn't study desire at all. They saw arousal, arousal, plateau, orgasm, and resolution. And then about 10 years later, they were like, wonder where desire goes. Let's stick it on the front, right? And so that's just how it had been modeled forever. But then in the year 2001, a new sex therapist, Rosemary Basson, she was a sex researcher, said, you know what? For many women, they do not experience sexual desire before arousal. And she went ahead and showed us that oftentimes for women, especially as we age and especially postpartum, that sexual arousal oftentimes comes before sexual desire. So if you look down here at the bottom, so that if a patient comes to you and is reporting low sexual desire, my first question is, okay, when you sort of get going in a sexual experience, do you then feel desirous? Or if you were to read an erotic book, would you feel desirous? If you were to see a sexy scene, is there something that can kick off that arousal desire pathway to kind of get you going? Often, like when we go to the gym and we're like, oh, this is the last thing I want to do. But then we get in the middle of the workout and we're like, I'm a goddess. Like, I'm amazing. I love working out. It can work the same way for sexual desire for women. So if there's something that can kick off your arousal desire pathway, then you do not need a medication, right? What we need, in fact, is actually just to seek out those tools that can help us feel aroused first, so that then we can feel desirous secondarily. Totally fine, non-pathologic, don't need any medications there. But that is such an important thing for people to know, especially us as practitioners. Okay, and then the last thing, this is my last slide, because I know we have so many awesome people on here and I want everybody to share, but is that the way that we think about sort of the sexual response generally is that there's all these things that can go on the inhibition side and all these things that can go on the excitation side, right? So each of us have our own sexuality. It's as unique as our own fingerprint. And the things that make that up work on the inhibition and the excitation side. Maybe it's our biology. Maybe it's our current life circumstances. For example, if we just had a baby and we're not sleeping and we're trying to share new duties with our partner, these things are all going on the inhibition side, right? Maybe we're having pain with sex, that's going on the inhibition side. And so when we start to build up all the things that are on the inhibition side, we're really going to start to have a hard time, particularly with desire, arousal, and orgasm. So what we have to do is we have to take a look at what those things could be on the inhibition side, and just one by one, the things that are changeable, try to move them either off or even over to the excitation side. There's a really great book called Come As You Are by Emily Nagoski, where she relates this to the brakes and the accelerators of sexual function. I think that's an awesome read for anybody who wants to understand more about this, and also for our patients who are looking to try to change their inhibition excitation balance in their favor, whichever, however they're trying to do that. So I hope that these first, original slides were helpful to the group and just sending us some clinical pearls to get us started with this conversation.
Thank you so much, Dr. Harper. I absolutely, and even for myself, this was an amazing review that you managed to compress in less than 10 minutes. So thank you. And now I want to build on what you said and take it to specifically the postpartum time period, because much of what you mentioned it with inhibition, everything that could get in the way of someone postpartum being able to experience intimacy and sexual health. Dr. Bogard, I'd like to move to you. You have an expertise in lifestyle medicine, especially sexual health, and you are an OBGYN who has practiced in a variety of settings. We're so excited to have you join us today. Can you help set the stage for us to talk about sexual health postpartum and talk about the postpartum physiologic changes that can affect sexual health? I think Dr. Harper mentioned one or two of them. I think, oh, you're on mute.
There we go. Can you hear me now?
Absolutely.
All right. Thank you so much for inviting me to be on this panel. And thank you, Dr. Harper, for that. Just excellent, those pearls, because even I forget some of those things sometimes. But yeah, I think for the most thing as practitioners, one of the things when it comes to discussing sexual health in a postpartum period is discussing it. Like you said, a lot of times patients have said, no one has ever asked me. And so setting the environment and asking the questions. And so one of the things I like to do is if it's someone that when I was in private practice, that I actually had an ongoing relationship with during the pregnancy, is to start those conversations before she delivers. And getting to know her situation as far as if she's married in a committed relationship, what the dynamics are of her relationship, so that after the delivery, I can have a real intimate conversation, meaning asking, how are things going with you and John, as opposed to, so what's going on with, with your sex life, but really getting to know her and her dynamics. And then after the delivery, it's easier to have that conversation. And she's actually more comfortable if you have that opportunity to start that during the prenatal period.
I think that's so important. I mean, there's so much to cover in prenatal health. And I think understanding where someone is coming from, what their relationships are like is so important. How do you explain the physiologic changes that happen postpartum and how that can affect sexual health to your patients?
Oh, that's an excellent question. So as we know, there's always the possibility of any trauma happening during any vaginal deliveries. And so vaginal lacerations and things that can cause increased pain. But one of the things that we as practitioners don't always take into accountability is that there can be the unseen changes, meaning that the nerve degeneration and things that can occur, even in patients who've had cesarean deliveries, who have pushed, they can have some nerve dysfunction. And so that in the postpartum period, she does have less sexual response. And so she doesn't get as much stimulation during the act. But also over the course, it's not so much after a first delivery, but when a woman has had a number of deliveries, or she's had some larger size babies, there are changes in the actual, how do I put it? Changes in the angles in the vaginal, in the pelvic floor, so that it can actually become more difficult to achieve orgasm. And so, as Dr. Harper alluded to, the clitoris extends all the way down into the vaginal wall, into the anterior wall. And so orgasm happens as a result of engorgement in that area, because there's nerves between the urethra and the vaginal wall, and then clitoris is going back there. And so when that angle changes, that space actually enlarges. And so it's more difficult to actually stimulate those nerves and those clitoral arms that are extending back. And so a woman who may have had no difficulty having orgasms before delivery, after delivery, she may find that it can be more difficult, just because that angle has changed because of relaxation of the pelvic floor.
And I think that's where we'll have Dr. Williams next, but not quite yet. Talk to us about what we can use to improve that. How about, and I usually talk to my patients about physiologic changes that can happen with breast or chest feeding. How do you explain that to your patients?
Oh, so as we know, one of the things is always going to affect her hormones. So a patient who continues to breastfeed can feel almost as though she's in perimenopause, menopause, because she's not going to have a restoration of her hormonal cycles as we normally would when she's breastfeeding. So these women sometimes can have ongoing dryness and pain with penetration intercourse. And so they may not lubricate as well, which makes sex more uncomfortable. And I think one of the things we have to remember is our patients tend to be young. And so sometimes we take for granted that they're just going to snap back and everything's going to be normal. And the patient also feels like, I should have just snapped back. I should be normal. Why is this still painful? What's going on? And so having that conversation to let her know that when you're breastfeeding, when you're chest feeding, you may have some changes that are synonymous to someone who's going through menopause, where there's drying and tearing and discomfort. And it's also going to affect her arousal and, her overall desire to have sex.
I think that's I know, no matter what the age, I always have to laugh a little bit when I'm talking to my postpartum patients, because no one wants to think of, if you're not anywhere near perimenopause and menopause, hearing your vagina might be that of a perimenopausal person is scary and frightening, because it's something that you see as being so far away. But I think it's absolutely right. So I think for our attendees who are listening, just to know like the takeaway. So with lacerations, there are changes that will make the intimacy feel different. And especially if people have had a history of, if it was a traumatic delivery, had a larger tear than normal, what we would consider a 3rd or 4th degree, breastfeeding or chest feeding is going to change the physiologic state. Even for people who are introducing formula, you are still going to have decreased estrogen levels. And that is going to affect ability to lubricate, ability to even heal too from those lacerations. And then adding on the changes that you mentioned to the pelvic structure with one delivery or multiple deliveries, I think is so important. And then I think bringing in the aspect of mental health. We mentioned with inhibition. So for anyone who seems to be doing swimmingly well, that still means you're fatigued. You have new routines. And then add on the fact that, there's a large number of people who are going to have postpartum mood disorders like depression and anxiety. And I would imagine that that's something that we also usually talk to our patients about,
Right.
having a huge effect on their on their ability to then enjoy sexual health and intimacy.
Right. And I think sometimes, like you said, bring in, especially if you had a patient who has had a traumatic delivery, you want to bring that patient in sooner than later. So within 2 weeks, and make sure she's recovering well overall. But if there's any evidence that she has more fatigue than you would expect, she seems to be just not recovering, be vigilant about doing labs to looking at her thyroid her function, looking at her CBC, making sure she's not anemic, because sometimes just those little things that we do can mean big changes for her. I have seen a number of times, and we always associate, if a person has had a large amount of blood loss with the delivery, that there's a correlation with having some hypothyroid. But it's something that a lot of women do have subclinical thyroid function, and we're missing it, and it's affecting their energy and their sexual function and, just their lifestyle overall. And so we have to be more vigilant about, let's do just the basics to make sure everything is recovering the way we would expect.
I think that, that's a whole other aspect too, where we think about it in terms of their overall well-being, but not necessarily the downstream effects on their sexual health. So what kinds of questions, I think Dr. Harper gave us some great questions to be able to ask in general. Are there any questions that, at 2 to 6 weeks, at 6 weeks, people are coming to us to ask, can I resume intercourse, or do I even have to? What kind of questions do you ask to elicit whether or not there might be an issue or an anticipated issue?
So luckily for me, now that I'm away from general, most of the patients who come to me, we know that that's the purpose of their visit. So, but in general, asking if she has resumed intercourse yet, and if she has, asking how it went. So was it painful? Was it enjoyable? And asking open-ended questions and giving her the space to explain what's going on instead of the yes and no questions. But then also, if she has not, ask her if she has any anxiety, how she's just how she is recovering, because a lot of times patients are waiting for us to just open the door. And once we open the door for that conversation, it's like a sigh of relief for them to get it out. And as you said, there can be anxiety, the mental health things that are associated with, she's just afraid. And she knows, her husband's waiting for that 6 week, waiting for her, her partner is waiting for that 6 week visit where they get to go ahead. And then she's like, but do I have to? And so just finding out what's going on in her head. If she does have some anxiety, why, what it is, and then having a discussion about her options as to addressing her specific concerns. And a lot of times, as we know, it's for the patient, it seems like this huge mountain, but in reality, it's a molehill for us to help with if we know what's going on and are open. And so for me, one of the things I had to learn early on, because of my lack of education in managing sexual health, I was not comfortable having the conversations. And so I didn't have any guilt or shame associated with it, but I wasn't comfortable because I didn't have the tools and the knowledge. And so if a patient would even have the courage to bring it up, I would either rush her through it or tell her, oh, this is normal after delivery, things will get better. But as I equipped myself with more knowledge, my confidence grew, which a patient picks up on. So if I showed that I was nervous, the patient backs down, and that's the end of that conversation. If I showed that I had shame associated with it, the patient backed down. But the more confidence I gained, the more I made this a conversation, like everything, like asking about the baby, asking about our sexual health, then she's comfortable having that conversation and letting you know truly what's going on. So sometimes we have to remember that we have to show that we're confident and I support you in this, and that there is no normal for recovery. And that's a question I get from patients a lot. in one way or another, am I normal? Am I recovering normal? There is no normal. Everyone's an individual. And so we have to be willing and have the time to have the conversation. And so if possible, I will make an appointment. If I notice that there is an issue, make an appointment specifically to have that conversation so that we're not rushed through it.
And you bring up such a good point. And I think I've been practicing now for about 4 years. And I've realized like one of the best things I can say, even if I don't know, is acknowledge it. Say, you know, I don't feel like it's my complete area of expertise, but I will connect you to I have tools to connect you to
Yes.
who can help. We can't all be experts in sexual health. There's a lot to it. And I think, but just knowing it, and the point of this webinar is hearing some of those resources, understanding what's out there, and then figuring out what resources you have in your community or are available. And we'll talk about those after we hear from Dr. Williams, just to know what we can offer our patients so they don't feel alone. And I think it goes a long way too, saying, I can help you with some basics, but I'm going to connect you to someone if we need to do something more,
Right. And that's what we have to understand, is that sexual health is an integrative thing. There's the emotional, the mental, there's the relational, and there's the physical. And so as the physicians, a lot of times we're experts in the physical and the hormonal things, but we may not be experts in managing pelvic floor therapy, which is huge and for so many women, just pelvic floor therapy, but also in having resources to connect them for counseling, for emotional support, things, because all of those areas, if one of those areas is dysfunctional, sexual health is dysfunctional for that patient, and we can't make one more important than the other. And so for me, that's one of the things, I pride myself on, and a lot of people in this community is realizing that it does take an integrative approach and reaching out to practitioners beyond just physicians, because it's what's best for the patient.
And that is a beautiful segue to Dr. Williams. Thank you so much, Dr. Bogard. You kind of set
You're welcome.
the stage for our learning with Dr. Justine Williams Roper. Dr. Roper, you have your doctorate of physical therapy and specifically focus on pelvic floor and women's health physical therapy. How do you explain the benefits of pelvic physical therapy to someone who is postpartum and how it might help them with intimacy?
Well, thank you so much, everyone. And I hope you can hear me very clearly. Thank you, Dr. Bogard, because that transparency and that honesty is so key in being able to push forward the wellness agenda, the educational platforms, and just valuable tools to really push that integrative approach. That's what gets people well. That's what gets people healthy and whole. And so I'm so excited to be here. Dr. Harper, thank you so much for all of your awesome education that you provided us today with. So the benefits, I really don't have enough time to explain the benefits, but I think what's so important in that we're all alluding to is that we all individually as health professionals play a different role. And I remember when I was 14 years old, the local hospital here put on a mommy and me period talk every year for young women to come to learn about their menstrual cycles. And when I went, I was confused, very uncomfortable, because there's a lot of other teenagers in the room with their mothers and they were also uncomfortable. So it's not fun. And you get all these pamphlets and you watch these corny videos. And that is the extent of the education that I got about womanhood, menstrual cycles, vaginal anything. And I think one of the major benefits that I pride myself on, especially when my clients come to see me, is the education that we provide. I believe that I would say 90% of my patients that come to see me are confused about anatomy. They're confused about what's going on with their bodies in general. And unfortunately, they may have amazing OBGYNs, but the amount of time that the OBGYN has to even spend with them to provide that education is very limited due to our medical model, right? And I'm sure that there are many OBGYNs that will provide more than 15 minutes of their time to attempt to educate, but the amount of time that's necessary to educate about postpartum, intrapartum, pre-pregnancy, it's limited. So when our clients come to see us, we spend a lot of time on educating. This is the flow of how the pelvic floor works. This is the process of what your body has gone through. Trauma, really scary word, but trauma is anything that throws our body off of homeostasis. In most instances, we associate trauma with a negative connotation, but trauma is a big event to the body. And that's exactly what pregnancy and birth is. And so explaining that and normalizing some of the things that our bodies go through in that period. And so education is number one, but then we also play the middle body: surgery, medication. There are a lot of other things that within the wellness and integrative model that are out now: laser, acupuncture, Reiki. There are tons of different floating. There are tons of different things that are offered, but a lot of people in communities, especially like mine, which I'd say Pensacola is about 10 years behind any other city. People aren't equipped with the knowledge to know what's out there. And so being able to offer a healthy, safe medium, right, that people can use their bodies to heal themselves, I think. Because, we're, as pelvic floor therapists, we shouldn't ever be against surgery or medication. However, we're big on using your body. We are specialists in muscle tissue. So how can we utilize your body to help you reach your goals, to help decrease pain, to help you be able to carry another child, to help you be able to go through this pregnancy happy and optimally? Hopefully that answers the question. And like I said, I can go on and on and on about the benefits, but those are my top: education and being able to empower people to use their own bodies.
I think so many things that you said, I was like, I need to remember to say that. Just the idea of what trauma is and changing it, not changing it, but just reframing what it is. And what I agree. When I refer patients to pelvic physical therapists, I say the first meeting, you're just going to get to know your pelvic physical therapist. You're going to learn about the body. It sounds like for someone who doesn't know, who either hasn't been to what is a postpartum or expecting parent, or is a provider who's never made a referral or actually hasn't gone themselves, what would you tell us what the first 2 to 3 appointments might look like? What are you doing with the patient and having them do at home?
Absolutely. So for my clinic, I'm a little bit different. I'm a hybrid model. So we're part cash-based and part insurance. So we're able to kind of set up our hours different. The average visit for generalized PT is 45 minutes. What I normally do is I have the client come in and we will allow them to literally have the floor. And the reason why I kind of changed that around, I used to pull this thing out, my pelvic floor model, and I would go through everything and say, this is this, this is this. But I noticed that people were so anxious that they can't even pay attention. So it's like, let's do that later. So we will at least go through pelvic anatomy, show the structure similar to what was during Dr. Harper's presentation, going through the layers, understanding length-tension relationship, organ tissues. That will be done hopefully in the first visit, but if not, the second. But the floor will be completely theirs. They will communicate their issues, what's happened. You can go back as far as you want to and allow the person to feel heard. Because again, I think in a typical clinical visit with a doctor of any kind, it's relatively short. And so they have a lot of space and room. And so then after that, I do like to use what they told me and formulate my presentation about the pelvic floor surrounding their complaints, right? So if someone comes in with urinary incontinence, let's talk about the options and how the pelvic floor and the anatomy surrounding that will present itself and may be contributing to your complaints. So after all of the talking has been done, based on what their complaints are and their comfortability level, we'll typically do a gross external assessment. We want to look at how you breathe. Breathing is like the number one thing when it comes down to pelvic floor dysfunction that can easily be adjusted to improve symptoms. Looking at how you breathe, how does your core look and move and operate? Are you overusing it, underusing it? your range of motion, of course, just the basic things, because when people think physical therapy, they think exercise, and a lot of patients and clients will come in dressed, ready to go. And that's not quite it, especially for pelvic floor therapy. And we do integrate that over time, but not the first visit. So after we've done a gross assessment, we typically will do a vaginal assessment. That will include looking at your reflexes, your voluntary contraction of your pelvic floor muscles. Are you able to do a Kegel? I like to call it a pelvic floor contraction instead of a Kegel. A lot of people are out here doing Kegels and it's wrong. You should be doing it and you're doing it incorrectly. And hopefully we'll have time at the end to discuss that. But looking at your reflexes, looking at the tissue color. The majority of my patients and clients who come in have never taken a mirror and looked down at their genitalia at all. And so being able to share and say, let's look at this together. Are you comfortable doing that? Maybe just you're not ready yet, but that's okay. At least being able to visualize it. Patients who are victims of sexual abuse and trauma, if they're not comfortable, we just start discussing the topic in ideal. There's a ton of information I can get from my general assessment of your breathing, your abdominal tissues, your glutes, your thighs, that will be super valuable in starting your regimen. And so once that's done and we're able to do the external, we'll do the vaginal assessment. We'll test the strength of the pelvic floor. Again, that length tension relationship. Are you tight? Are you weak? The majority of people who are having pelvic floor dysfunction symptoms aren't necessarily weak. They actually have a lot of guarding in their floor as a result of the trauma that they've endured, especially during having given birth. We'll look at pelvic organ prolapse, all of those things. And once we collect all of that data, sometimes that can take 2 visits and sometimes it can take 1. We formulate a treatment plan. Do I need to see you 3 times a week, once a month? It depends on the client's lifestyle. And then we go from there. So that can literally take, like I said, the first 1 to 2 visits. And depending on what we found, the 3rd visit or so will get started. Do you need to do biofeedback? Do we need to be doing strengthening, exercise, stretching, breath work? The list can go on and on. So that's kind of what's compacted into all of those first couple of sessions.
I think that's so helpful for people to hear because, like you said, usually physical therapy, you think exercises, and pelvic physical therapy is so I don't know about other types of therapy, but it's unique in that sense that it's much more than just exercises. And so to that end, do you have any brief recommendations about how someone should think about whether or not they should be going to a pelvic physical therapist during pregnancy or specifically in the postpartum period?
I think it should be any female at any point, any woman at any point. But again, because there is so much preventative information that is provided to any woman that comes into our clinic that maybe even thinking about childbirth 10 years from now, that if I got them intrapartum or peripartum or postpartum, that it's somewhat late in the process. Mm-hmm. So, and what I find is that during birth, there's a lot of mind-body disconnect that happens, and let alone if you didn't have the mind-body connection prior to giving birth. We have a lot of catching up to do. And so there's so much preventative care that can be provided even before pregnancy is even thought about. But if a patient or client does need or is symptomatic, pain, urinary incontinence, anything of that nature, weakness, deficits, they need to be in therapy. I try to see anyone intrapartum as soon as their practitioner, OBGYN or midwife would clear them to do so, especially high-risk patients. But any patient typically around 17 weeks would be good for intravaginal, but any point in time, if we're doing anything external, and especially at the 6-week clearance date, that is very controversial within our field. 6 weeks postpartum is very early, to be honest, to be doing a lot of return to anything, especially like return to run, return to intercourse. I mean, there's so much, as we've discussed earlier, anxiety, but true physical ailments that people and women are still going through. So, I mean, the earlier, the better is the best way I can answer that question.
I think too, for anyone who's listening, who's expecting or providers who have patients, something you touched on, anyone with a history of trauma, with the history of anxiety, vaginismus, those are definitely people that pre-pregnancy, you want to get them involved in pelvic physical therapy. There's a slew of other conditions that, or people who have weakness and incontinence and are really worried about the effects of pregnancy on them. And I think just for, it sounds like too, just for education, if our patients don't have access to resources, seeing a pelvic physical therapy just to learn and figure out, even if they don't think they have an issue, just to learn about their bodies would be a great way in certain areas to at least utilize one, or maybe consider using a pelvic physical therapist virtually.
Absolutely, because the first thing I hear my clients say is, when I got on the table to deliver, they told me to push and I didn't know what that meant. And they'll say they told me to push like I wanted to poop, and that's really hard to do if I'm not sitting on a toilet. So the voluntary lengthening and contraction of your pelvic floor, which is the lengthening portion is necessary. Most people don't know the uterus is doing a lot of the contraction and pushing. The pelvic floor has to actually go towards the ground in order for the baby to come out of the vaginal canal. What?
Yeah.
What? So just literally education.
Yeah, that is so incredible. I think I would love to hear, in the interest of time, some of your favorite resources to share with your patients about sexual health as a pelvic physical therapist. And then we can always send our attendees a list as well that you've helped curate.
Yeah, absolutely. So I did a mind dump. Pelvicguru.com is really, really awesome. Not only is it a directory, but it has tons of resources in regards to pelvic health. It lists out tons of conditions and resources for those types of conditions on there. ASECT is also really good. The American Association for Sexual Educators, Counselors and Therapists. Yes. And so that's a really good resource as well to find a provider in regards to sexual health and dysfunction specifically. And tons of social media accounts I have, and I can list those out, from the Minority Sex Report to the Vagina Rehab Doctor. I mean, all the resources in one book that is really good is the Vagina Bible. And that is really, really awesome in just setting up just the basics of anatomy and things of that nature.
Amazing. Thank you so much for sharing. And we'll be sure to get these great resources from you and send them to our attendees after. Dr. Harper and Dr. Bogard, I wanted to come back to you briefly to talk about additional resources to share with patients. I know we reviewed, I think, Dr. Harper, one thing that I wanted you to give our providers a little bit of assistance with is, we talked about, and Dr. Bogard talked about, asking open-ended questions. Are there 2 or 3 questions that you think, if we say it enough, we'll get in the habit of saying, that we can ask to address postpartum intimacy with our patients?
Sure. Yeah, I think that, when I approach this in practice, it's always to really create a safe space, right? And so the way that I usually like to start these questions is to say, you know what, most people will have some sexual concerns, questions, or problems after birth. And I would love to be, the place where you can go to with those questions. And oftentimes at that 6-week visit, our patients have, not been sexually active. And they're, like y'all mentioned, kind of, eyebrow raised, worried that when will they have to go back to it? And I think just normalizing whatever the experience is for that patient, and emphasizing, as everyone's talked about today, that everyone's recovery and parenting journey is different and separate. And just a 6-week stamp of approval from your OBGYN doesn't really mean much of anything. There's lots of factors that come into play other than just, are your lacerations healed, right? We don't do a really, thorough pelvic musculature exam like Dr. Williams would. There can definitely be, deeper tissue damage that we're not able to appreciate on our regular pelvic exam. So whenever you're doing your exam, I would challenge all practitioners to examine more than just the mucosa. Obviously, we're looking at the cervix, but to feel around on that pelvic floor musculature. And if you find any spots that are particularly tender, we can anticipate that patient's going to have painful sex when she returns back, and go ahead and initiate that referral right off the bat. Also, obviously, if she's having a lot of dissent, these are definite triggers for go ahead and refer her. We want to be proactive rather than reactive for this patient, because once we get her into this negative cycle when it comes to sex, right? So if we're like, okay, you're clear, she goes back and it's painful or she's dry, then we're going to start her in this pain cycle where she wants to avoid sex. We're not being able to be aroused as easily. So there's a lot of things where, especially in sex medicine, we want to be proactive rather than reactive. I also just wanted to mention really quickly about vaginal estrogen, right? So we all know that if a patient's, making milk and for whatever reason, that her estrogen is going to be low, at least for those first 6 months. And we can always add just some topical estrogen, just like we might do for our patients who are peri or postmenopausal. Sometimes in my experience, a lot of times insurance won't cover it for these patients, but you can grab some from the sample closet. She can pay for it. It will make a huge difference. And oftentimes a little bit goes such a long way. So just adding a little bit of topical estrogen to promote healing, especially if there's some, lacerations that are slow to heal or some granulomatous, tissue in the vagina, that estrogen will really help that to heal quickly. But definitely topical estrogen, early pelvic floor referral, and normalization of whatever her situation is. And to emphasize that there's other ways to be intimate with your partner other than penis and vagina sex. And we can utilize those methods as long as we need to, and just try to keep those lines of communication open.
I think that's a great open-ended question. And Dr. Bogart, do you have a question or two that you like to ask? I know you mentioned some earlier. Oh, you're on mute. You're on mute.
I'm so going to get this right. I just said Dr. Harper did an excellent job, but that's the same for me. Is I like to ask, tell me, so that it's open-ended and I can hear her words and hear it in exactly how she feels, as opposed to her responding to my yes or no question. So tell me how things are going at home. Tell me how things are going in your relationship, and just give her the floor to say what's going on. Also, Dr. Harper mentioned some of the treatment options. And so I always want to make sure that we keep in mind, especially with our patients who are breast chest feeding, who we may not want to give estrogen to. And some patients, they don't want to do birth control, any type of hormones for whatever reason, but there are other treatment options. There's a product, and I don't think we're going to name any products here, but there's one product that I use that works really, really, really well. That actually helps to increase oxygenation to the tissue. So it does help to restore blood flow and helps the tissue heal. So for those who have had lacerations, for those who are breastfeeding, it's almost the equivalent of doing a laser procedure without actually doing the laser, the results that you get. And it has been something that has helped a number of, including my patients who've had cancer and have really severe vaginal atrophy. It's a product that has worked wonders that I really love to use. And it's a topical product that patients can use at home. But also the laser procedures, the RF procedures, those all work really, really well. But just having the conversation with a patient and letting her know that she has options. Yeah. It's not just you take the hormones or you take the birth control pills, but there are other options where we can support you to make intercourse, sex, connection enjoyable and pain-free, in addition to the resources to other pelvic sources for treatment.
And to your point, I do like to reassure patients that when we do give them vaginal estrogen to use, the systemic absorption is going to be minimal. And
right.
The time course we're using it is short. So especially for those people who have worked so hard to be able to build up their supply. And we know the studies for combined oral contraception with estrogen and progestin are mixed on how it can affect lactation. But I tell them, this should not have any effect on your ability to build
continue,
up.
right?
Yeah, but definitely. And I love at where I work, the pelvic physical therapists are often the ones, if I haven't already, who email me and message me and say, I think this patient could benefit from estrogen. Would you consider it? I'm like, yes, thank you for,
Absolutely.
I'm sorry if I missed it. But, and I would say, you've both mentioned, we talked about estrogen, we talked about pelvic PT. Dr. Harper, can you tell us more about the tools prenatal healthcare providers have to address sexual health? just based that are not necessarily pharmacologic or like PT related?
Certainly. Yeah. So when we think about, really sexual function for anybody, we always can think about what are the evidence-based, things that we can do to intervene. So we know pelvic floor PT works. We know that we have some pharmacologics that can work, but also education, just like Dr. Williams was talking about, is actually therapeutic, right? So any source of education, whether it's recommending a book to your patient, whether it's recommending a platform like Rosie, which that's really all we focus on is women's sexual health, the educational piece can be therapeutic to women. There's also erotica, right? That if a patient is looking to sort of say, hey, what can I do to increase my goal? So her goal is to increase intimacy. What can I do to support that? Then we can recommend erotica to our patients, which is actually another evidence-based way to improve sexual function. We did a study of Rosie users. We have erotica on the Rosie platform, and erotica was shown to improve all aspects of sexual function: orgasm, arousal, desire, and lubrication. So that can be really powerful. If a patient prefers not to take a medicine or whatever, we have so many resources at our fingertips to support these women. And also over-the-counter lubricants, right? So if someone wants to avoid hormones and we don't have, and it's dryness is the issue, then lubrication obviously can help with dryness, but also has been shown to increase sexual pleasure just kind of all around. So you can normalize that for the patient. Lots of people use lube, not just people who are having trouble with, hormonal dry tissue. It can be fun. Like there's nothing wrong with it. There's nothing wrong with you. These are all normal parts of healing. Why don't you give it a try and kind of see what you think? And it can just be a little bit more of a lighthearted way to approach the conversation and help to normalize the experience for the patient.
Do you have when should someone consider a sex therapist?
Yeah. So, I would say that if someone is having a hard time in their relationship, right, if they're trying to sort of grow or work through a sexual issue, but their partner, for whatever reason, they're getting a lot of, pushback, or they're not able to facilitate healthy sexual communication, time for sex therapy, 100%. Also, if there's a specific issue, sexual pain, sexual trauma, anything that's been around for more than a few months, you probably need a sex therapist to help you work through that in a healthy way, right? And not just like a stuff down, get over it way, but in a let's try to work through these issues so that then we can go on to lead our fullest sexual lives. And I think there's a lot of misconception about what is a sex therapist. A lot of patients sometimes think, and even practitioners, I think, what's going on at sex therapy? Like, what are they watching them touch themselves, or what's happening over there? And actually, it's just a therapist. It's either a marriage and family therapist, or a social worker, or a psychologist who's had extra training by ASECT, the credentialing body that Dr. Williams was talking about, to be completely objective, right? They have been desensitized. You can't tell anything to a sex therapist that they haven't heard before. And they also are really understanding of how important sexual health is to our whole lives, right? It's not just one facet that we can close the door on. It affects every aspect of our relationship, of our sense of self, of our ability to contribute positively in the world. And they understand that integration of sex and our sexual health into the rest of our lives. And they're just wonderful at being able to help people through that. So sex therapists are definitely another person who would be well represented on this panel as part of our, integrative approach to sexual health, for sure.
Thank you for that. Dr. Bogard.
I was going to add, because you kind of alluded to this, but it's also whenever important to include a partner in the conversations, because sometimes the partner may have some anxiety about getting back into intercourse. And so if possible, if the partner is coming to the visits, but include the partner in the conversations, because that can go a long way to help with their communication between them.
That's a great point, especially if the partner witnessed something traumatic.
Exactly.
Watching this person in their new body use it in different ways that are incredibly impressive, but might be intimidating. I think it's really nice to be able to have a conversation with that individual, but then bring in the partner to help normalize the discussion too. In the interest of time, I knew this conversation would go over, but I was going to try and wrap it up in 60 minutes. Our panelists, I believe, are free for an extra 5 minutes to answer some of the questions you've asked. If you can all in the chat to the attendees, write your favorite lubes. Dr. Williams, I wanted to ask you, because we had a few questions about insurance coverage. Yeah. So is preventative pelvic floor therapy during the antepartum period covered by insurance? And I imagine it differs state to state. And then, yeah, that was one of the questions we had gotten.
Right. So can you guys hear me?
Mm-hmm.
Okay, so for any person who comes to physical therapy, they need to if they're using their insurance, they typically do need some form of concern to go. So if it's more falling under the wellness category, likely not. But if it's some form of concern where they generalize weakness or they're having some symptoms or something like that, perfectly fine. ICD-10 codes are endless. You can absolutely get a referral and or go directly. Florida is a direct access state. So you can come to a physical therapist for up to 30 days without a referral. So it really just depends on the state. But most of the time, if you have a concern, we can give you ICD-10 code.
I think that's great to know. And there's also, I've noticed several more pelvic physical therapists who are offering virtual consultations. And I don't think that's right for everyone, but I do think for people that might be in an area where they have limited access to an in-person pelvic PT or can't get coverage from insurance, but can pay a certain fee, we can give you a list of virtual places that offer virtual appointments.
Absolutely. And the resource that I gave, pelvicguru.com, I can add more directories that have therapists, even sex therapists, personal trainers who focus on pelvic floor. All of those will be included. I've seen clients all around the world, Israel, everywhere. And we do a lot of self-guided work when it's virtual. So yeah, it's possible.
Do you have any thoughts? Have you, Dr. Williams, are you familiar with like the Mutu system and Every Mother? Do you have any thoughts on how, if patients should be using those resources, or do they need a little bit more guidance?
So here's my opinion about it. It's very difficult to find your pelvic floor, understand what specifically you need without specifically being addressed by a health professional, especially if you're symptomatic. I think Mutu is a great system for those who may be asymptomatic and just truly want to continue progressing forward, working on their body or in tune with their body and those types of things, intrapartum or postpartum. However, I think it's so beneficial to see a pelvic floor practitioner at least once in person or virtually so they can direct you and you can really make sure you're doing things safely.
I think that's really helpful to hear and for people to keep in mind. Okay, this is a bit of a big question, but let's give it a shot. What are some of the best ways to recover your libido after a baby while breastfeeding? We mentioned some of the resources, but I don't know, Dr. Bogard, Dr. Harper, any other pearls? I have my own thoughts. I'll save them to the end.
I was muted. That is a really, really good question. So because I know when women see when they're breastfeeding, it's like your breasts have taken on a new function. But number one, making sure she's not stressed and she's not tired. Because as you know, breastfeeding is a huge metabolic demand on the patient and she's going to be tired. So getting adequate rest, making sure she has, she's drinking plenty of fluids, but just getting herself, making sure she starts off taking care of self and that she has that time to feel energetic and so that she can optimize having desire and response. And so it begins with her taking care of herself first and finding the space to not feel guilty about not being mom for a minute, but being the sexy partner for her partner, her connection with her partner. But for me, it's always about starting with taking care of self and creating the space within herself to get back to connecting with her partner.
I think that's so important to keep in mind. You have to be better for yourself before you can be able to be better, not necessarily better, but be present for others.
Be present,
those,
right?
Those issues. I want to be mindful of everyone's time. I have so enjoyed getting this group together and learning from you all. I'm grateful to our panelists who span multiple time zones and states for joining us today to talk about this very important issue. And I love knowing that there are so many allies in this space and so many educators who are every day doing something to improve people's understanding of this topic. Thank you all for joining us. We are going to make this recording available, and we will send a kind of one-page summary so that you can, some of these pearls that were shared, you can keep it with you and share with other providers or with other expecting or postpartum patients. It is a beautiful day in San Francisco. I hope it's just as beautiful where you all are. Have a great day, everyone. And if you have any other questions, feel free to send it to us and we will try and address it privately.
Dr. Harmafar, I did see the question pop up about that product that I was talking about. I will send you a link for it so that in the responsive email, you can include that in the email.
That would be great. Thank you. I'm going to ping you three individually to get to pick your brain on those resources too. But okay. Thank you all for your time.
Welcome. Thank you.
Thanks. Bye-bye.
Take care. Bye-bye.